Today's topic is decision-making capacity. Decision-making capacity refers to a person's ability to give informed consent. And this requires the individual to be able to understand information and to make a considered decision based on the information. Now, sometimes it's very easy to determine when a person lacks decision-making capacity. For example, small children lack this. In other cases, it can be far more difficult. For example, participants with dementia may understand information one day and not the next day. Or someone who's suffering from psychotic delusions may actually understand the information and might be able to paraphrase it for you, but may not understand how the information relates to his or her real life situation. Sometimes we speak of the ability to appreciate the information. Today, we're going to look at how researchers can try to proceed when they're faced with such challenges.
Well, I think also that we need to look at this issue in a broader context. We need to understand the situation of science, which in order to be helpful and produce new knowledge that will address the needs of people that have diminished capacity or severe psychiatric problems, on the one hand, still have to be considerate of protecting their safety and to be considerate of their humanity.
Jean, you're absolutely right. We're really engaged here in a balancing act. And it's a balance that our regulations certainly have not struck yet, in that the National Commission that produced the Belmont Report had urged that people with mental health disorders be considered a vulnerable population. We know that that can lead to certain risks. On the other hand, without them being considered a vulnerable population, we don't see the heightened protection. So we're largely dependent on the conscientious researcher or IRB member to navigate these waters. Today's interview is with Dr. Phil Candelis, who is a psychiatrist at the University of Massachusetts Medical Center. Dr. Candelis is a member of the National Institute of Mental Health's Ethical Issues in Human Subjects Research Committee, and he's also a recipient of a National Institute of Health grant to study the competence of human subjects in research. Jerry Kuchar and I spent some time discussing informed consent, but we focused on what's expected of investigators, the duty to provide information, to avoid coercing participants. Today, we also want to discuss informed consent, but focusing on what's expected of participants. Can you tell me what are the key abilities or functions that we're looking for in participants when we're trying to get their consent for research?
Well, I use a model in my research that was articulated some years ago by Applebaum and Roth, and then again by Applebaum and Grisso. This identifies 4 different domains of decision-making capacity in a hierarchy, let's say, from the simplest to the most complex. This model asks individuals to communicate a choice, to be able to communicate a choice, to be able to understand the relevant information that they're being given, to manipulate information rationally, to reason through their decisions, and to appreciate the situation and its consequences. Altogether, they're important elements of decision-making capacity, both in ethics and the law.
Could you tell me a little bit more about these 4 different functions, maybe with an example?
Of course. Communicating a choice, for example, the simplest of the standards, if you will, simply asks that people tell you what they want done. It's behavioral, it's reliable, it's easily replicated from setting to setting. Now, some people may not even meet this simplest standard because they vacillate, they're ambivalent, they change their minds frequently. But generally, most people can communicate a choice about what they want done. Understanding relevant information is about expressing the important information in one's own words, being able to understand it, to paraphrase it, to get a sense of the important pieces that make up a research protocol. And that involves retaining and ordering information too. As you go up higher in these standards, reasoning or manipulating information rationally is the sense that there is a cause and effect relationship between one's thoughts, that there is some logical sense of how you get to your decision. Now, you don't have to be supremely logical in how you get to the your final choice, but there has to be a sense of what the major factors are. And this is very much a part of this model that's been described and that we use frequently in clinical research. Now, appreciation of the situation and its consequences is a much more emotional, it's more personalized and particularized kind of standard. It's not as cognitive. It's an attempt to apply the situation to one's own condition. Denial, for example, challenges us to use this kind of a standard in assessing capacity.
People sometimes speak of decision-making capacity, and at other times they speak of competence. Are these concepts the same?
No, conceptually they are the same, but competence is the finding of a court of law, technically. So in the clinical and research setting, we speak of decision-making capacity. Now, the courts generally abide by the clinical assessment or the research assessment when it gets to that point, but these assessments don't get to the court generally because clinicians document that if a court of law were to take a look at this clinical exam, this research assessment, that they would likely find that someone has capacity.
Does the diagnosis of a mental disorder like depression or schizophrenia automatically indicate that a potential participant lacks decision-making capacity?
No, absolutely not. There is a developing literature on the capacity of persons diagnosed with mental illness to retain decision-making capacity, particularly in entering research. This represents a status kind of standard, painting a whole population with a broad brush of incompetence simply by virtue of their status as persons with mental illness. And in fact, medical illnesses themselves have significant pressures that undermine capacity. Desperation and strong trust, for example, in oncology, in cancer protocols, can undermine the decision-making capacity of individuals who are desperate to get into research or who are interested in clinging to the smallest bit of hope that a clinical drug trial might represent.
So when is a formal assessment of capacity in order?
Well, if the recruitment process or the informed consent process or even conversations with your potential participant raise questions about the standards that we talked about earlier. So if someone has difficulty maintaining a stable choice, communicating a stable choice, if they're having difficulty with the important information that's being divulged about the research protocol, or they're having difficulty reasoning through how they got to their decision, they can't appreciate that it applies to them, to their own condition, those are red flags for considering a decision-making capacity assessment.
Do you think that those who provide oversight for a research study, let's say an IRB, should ever require a formal assessment of the decision-making capacity of all prospective participants?
I can imagine studies in which the risks are high enough and the vulnerability of the group of research participants is significant, where an IRB could require capacity assessments for all of the research participants. IRBs should be free to exercise their community's values and their own values to assess the informed consent process, whether it's through use of consent auditors or formal capacity assessments. I worry when we're talking about assessing entire groups of patients that we are getting to the marginalization and the stigmatization of groups with mental illness, for example, who have chronically been thought to lack capacity. So I think there is a tension between requiring good research protection and making sure that we're not stigmatizing an entire research subject population.
Who is in the best position to determine decision-making capacity? Is this something that your average researcher can do, or is a specialist usually required?
I agree with those who say that any clinician or researcher with a good background in mental status and a good sense of diagnosis and the way illnesses affect mental status can do capacity assessments. My sense is that mental health professionals, psychiatrists, do get asked to do this more frequently, so we have a bit more expertise and a bit more experience in it. And I think I also agree with those who say that we might be better at recognizing groups of potential research subjects who may have particular difficulties, like the chronically institutionalized, who may feel the pressure or the coercion of their setting, or persons with mental retardation who may be too eager to please a researcher, or perhaps those with depression who are so hopeless that they can't imagine that anything else would help them except the risky research.
What does the process of assessing capacity look like? How does one go about it?
Well, you want to make sure that the research protocol itself drives the assessment. So because capacity is the ability to perform a specific task, you want to make sure that the research participant has an understanding of the important pieces of the research protocol that you feel are important as well. You want to make sure that they can reason through the process, figure out how they got to their decision, and make sure that they appreciate that this applies to them and that this is in fact research and not clinical care.
I know that in the clinical setting, decision-making capacity is sometimes assessed on a sliding scale. If a patient is seeking to be admitted for treatment and it's considered to be low risk and highly beneficial, the bar might be set fairly low, whereas if the same patient later wants to be discharged against medical advice and there's some maybe concern about suicidal intentions, the bar might be set much higher. Let me ask you two questions. Do you think it's ethical to have a sliding scale? And do you think that that ever happens in the context of research?
Yes and yes. I think it is ethically justifiable. I agree with those writers who find it a practical way to apply the 4 decision-making standards that we've been talking about. So where there is lesser risk, perhaps less capacity will be necessary. This is part of the moral component to assessing decision-making and goes beyond the kind of description of the ethical and legal standards that we talked about before. Now, as the risks go higher, let's say someone is interested in participating in a randomized clinical trial, there's placebo control, double-blindedness, there's more complexity and more risk. It seems acceptable to require a greater level of decision-making capacity. Some say that this maximizes individual autonomy at one end of the spectrum and a kind of a beneficent parentalism on the other.
If a person is deemed to lack decision-making capacity, does this mean that he or she cannot participate in research?
Well, actually not. There are surrogate decision makers and legally authorized representatives who can give consent for an incapacitated individual. The federal regulations are clear that we can obtain informed consent from the research participant or a legally authorized representative. And there are dual consent models that have been described in the literature, in use, for example, for Alzheimer's protocols when someone might lose their decision-making capacity over time. And under those circumstances, institutions do include family members, for example, early on in the research. So there's a good sense of what the research subject's values are, what their choices might be down the line.
How should surrogates go about making decisions regarding participation in research?
Well, there are 2 models that are generally recognized in the literature, substituted judgment, as you know, and best interests. Substituted judgment is the model in which a surrogate decision maker stands in the shoes of the principal, of the individual, and tries to make decisions as if they were that individual. They take into account the values of the individual, the conversations that they've had over time, and the like. If that's not available, then the best interest standard comes into play, and under those circumstances you use what people like Beecham and Childress call the truisms of healthcare, that health is better than illness, life is better than death, and the like.
Many mental health disorders are episodic. For example, someone with schizophrenia may go months without an episode, or someone with depression might experience just a couple of episodes in a year. Given this fact, is it possible to avoid difficulties with decision-making capacity simply by timing when the informed consent process is begun?
Sounds like a reasonable approach. Many mental disorders are episodic. They're state-dependent. They fluctuate over time. So it may be possible to wait to obtain informed consent. The difficulty is that many research projects, trials, are time-sensitive. So clinical drug trials, for example, may change from week to week, and the research subject must understand the changes that are going on in order to go on with the next step. So it's always important to make sure that you have an identified decision maker who can give informed consent.
Are you aware of any research on mental health consumers' attitudes and preferences regarding the informed consent process, and especially the issue of whether or not they are allowed to participate in research when they lack decision-making capacity?
There is a developing literature on the altruism of some of our research subjects. I'm thinking of Laura Roberts' work here and her group, who determined that there was a good sense of altruism, of a willingness to help others with the same condition as some of her thought disorder subjects. And David Wendler has some work out of NIH where he asked folks who were at risk for Alzheimer's whether they would be interested in entering research even after they became incapacitated. And he got a strong positive response. So I think there is a developing literature that identifies both altruism and a willingness to participate even after incapacity. I still think we need to have discussions about how much risk the community is willing to allow individuals to take when they enter research protocols.
For behavioral health consumers, I think that the capacity to give consent and the assessment process can be seen as a barrier to their access to research, to be a participant in order for altruistic reasons, in order to make a contribution. And I wonder if people with severe and persistent psychiatric problems aren't considered a vulnerable population or a special class. Why is capacity a particular issue for participation in research for them?
Jean, that's a great question. I mean, on the one hand, I think being sensitive to whether people have the 4 different functions or capacities that Dr. Candilla spoke of is crucial. I mean, unless someone can understand the information and appreciate it, for example, you're not really getting informed consent from them. And if they can't give informed consent, then they should be offered extra protections. But in a sense, you're asking whether they're being screened or selected for capacity assessment in an unfair manner.
I think that there's a lot of prejudice of people that do consenting process. Oftentimes it's lay people who do the consenting process, not a trained psychologist. But I think the biggest problem for me is that these considerations aren't necessarily applied when conducting like general research. That the issue of a person's capacity seems to be a particular concern for people that have behavioral health problems.
I think you're right, Jean. And again, it's kind of a balancing act because given the fact that our regulations don't require routine screening for these capacities, and that researchers often have conflicts of interests or they're under tremendous pressure to recruit participants into their studies, it can be helpful for IRBs and others to be cognizant of certain risk factors for lacking capacity. Some of those might include mental health diagnoses like dementia, for example. But you're absolutely right that there are many other risk factors that could include things like just the person's level of education. And so we do need to be sensitive to these topics, but in a consistent manner.
I think another issue is the capacity to give consent when a person is in a psychotic episode. And that's where we began our discussion with research participants. I would guess that there are all sorts of social taboos that a researcher should know if they're going to be engaged with a homeless population or people of color or any subgroup or different culture, that it would be important to be sensitive in terms of the social relationship. besides studying people, so you would be able to ask the right questions.
So researchers want to put you into a little box, you know, and so like in the particular study I was in was for homelessness. They insisted that I was homelessness for a reason. Either I was a drug addict, I was an alcoholic, I was abused by my parents, I was none of these, you know, and so they just wanted to insist that I had to be one of these. I had to fit into this little category, and I think that's where researchers often make mistakes, that everybody doesn't fit into a little box, you know.
The good thing about it, everybody just don't feel the same way about it. So you might get, everybody might take this, like maybe say for instance they're researching the type of medication. One person may get this reaction, another person get this reaction, another person get that reaction. So basically, you know, it's hard work because everybody don't react the same way.
Has anyone here ever been asked to be in a research study while you were in a psychotic episode? Or when you were having real problems?
In my situation at the time when I entered the study, I was just experiencing quite a bit of schizophrenia, paranoia, and the voices. And I thought it was a really heavy laden burden on my head at that time.
Consumers, on the other hand, sometimes are really concerned that they can be turned away from doing research that they want to do because someone else is saying they're not competent. So it's a very difficult issue.
Would that base them on the state of mind that they're in?
Well, and then there are tests you can give to people to see if, but then a lot of times other people that are in studies that don't have a psychiatric condition, they're not given those tests.
Right.
So it's a more complicated issue.
Well, Gene, you're certainly right in the way that you concluded that segment there. It is a complex issue, and it's important for people to understand that just because an individual lacks decision-making capacity, it doesn't mean that he or she can't participate in research. We do, as Dr. Kondilis mentioned, have dual consent models where perhaps someone in the earlier stages of dementia might say, when I reach a certain point and I'm incapacitated, I'd like my wife or spouse or partner to make decisions for me. We have surrogate models that are used frequently in medical decision making, and so it doesn't need to be an obstacle to participation.
Well, I think that there are two issues. First of all, there are people that can't give consent, but can go on to participate in a study. In biomedical studies, I think that's clear. On the other hand, there are people that can consent to be in a research project, but then go on to face obstacles to that participation. And I think that our discussion group quickly went on to talk about the obstacles to participation rather than simply focusing on issues of competency to give consent.
The pressure of the study, you can get in a way of getting up. It makes you upset because the questionnaire and what they're asking you. You know, you don't mean to, but it happened. You know.
You mean during the process?
During the process. Like I say, I do a survey every 6 months. And before, you know, they get really deep into it, they ask me, now if you get to that you can't handle anymore, you get depressed, well, stop me and we'll quit, you know. But I go all the way through it, you know, because I understand, you know, this is me. I'm trying to find out about me also, you know what I'm saying?
So they were being sensitive
Right,
to your
right.
needs and
my
being
needs,
supportive.
right, and it was really helping me out also.
I was in a study about mental health, and the person taking the interviewer was a mental health consumer too. So I didn't feel like I had to be, you know, looked down upon, or that they were afraid to be in a room alone with me.
It's downright personal when they're asking about sexuality, about drug use, about alcohol use. And knowing that you were a fellow consumer, I think, helped with the honesty.
So part of respect is just being with someone who understands where you're being, and also doesn't look down upon you because, gee, you're being paid. And in a study test, I just felt like a big guinea pig that I was just going to be. It doesn't matter whether, why did I come into that study?
While the issue of competency or decision-making capacity to give consent to participate is important, as we have seen in this discussion, that also the capacity of people to participate in the research is also very important. And our discussion group really identified those things needed by researchers, their role and responsibility in enabling people to participate in research. For example, being sensitive to the needs of the participants, perhaps providing them a longer time to respond to a question, providing breaks. I think that those are important. I think establishing a rapport and a sense of comfortableness with people that have behavioral health problems is really key. And I think this requires a whole new skill set for scientists beyond training and standardized interviewing, for example.
Well, you're right, certainly a whole new skill set and a new sensitivity or level of awareness. Listening to you, I'm struck by the fact that we have a notion of reasonable accommodation in the workplace, but in the context of research, this idea of reasonable accommodation for the needs or medical needs of participants has perhaps been insufficiently addressed. And, to set this kind of in the ethical language of the Belmont report, I think in recruitment, we're very often focused, during this informed consent process in particular, on showing respect for persons by obtaining informed consent or on offering extra protections for those who can't grant informed consent. But what you're really saying is there's also a larger issue of justice here, that we not unfairly target people to be screened for decision-making capacity, and maybe even more importantly, that we offer reasonable accommodation to enable participation as much as possible.